I am Nicolette Black-Ballard,
And I'm Megan Cunningham.
and we are covering chronic kidney disease. Chronic kidney disease is defined as a presence of kidney damage or an estimated GFR of less than 60 milliliters per minute, persisting for 3 months or more. It is a state of progressive loss of kidney function. It ultimately results in needing dialysis and transplant and ends with end-stage kidney disease. So the etiology behind it, there are a lot of different things that can cause CKD. The most common are diabetes and hypertension. You can see from the list that diabetes type 2 accounts for 30 to 50%, and hypertension accounts for 27.2% of people who have CKFD. So it's very important that this population of people with diabetes and hypertension are assessed for their kidney function and assessed for any damage that may be present, and that they modify their diets and kind of modify whatever risk factors they can to prevent further kidney damage. CKD may result from disease processes in any of the 3 categories, which are pre-renal, intrinsic renal, and post-renal. So the patho behind CKD is, so you have an initiating factor there in the middle. So it can be the diabetes, the hypertension, any exposure to a toxin, autoimmune disease, and ultimately that leads to a decrease in the number of nephrons. The decreased number of nephrons leads to activation of vasoactive mediators, cytokines, the renin-angiotensin-aldosterone system, and increased growth factors. All of these changes cause structural and functional changes of the surviving nephrons, and it causes them to have like an adaptive hyperfiltration to compensate basically for everything that's going on. And that hyperfiltration leads to an increase in intraglomerular capillary pressure, and that leads to accelerated cirrhosis of the remaining nephrons, which goes back and leads to a decreased number of nephrons. So it's kind of like a cycle that continues to happen over and over again until you progress through the different stages and end up with end-stage renal disease. So the clinical manifestations and the symptoms, for the most part, a lot of people are asymptomatic, and a lot of people who have CKD do not know that they have it because they are asymptomatic, and symptoms usually develop later around stages 4 and 5. They result in nausea and vomiting, loss of appetite, fatigue and weakness, peripheral edema, muscle cramps, sleep disturbances, dyspnea due to pulmonary edema, dry and itchy skin, headaches, erectile dysfunction in men, and hypertension that is very difficult to control.
So diagnosing chronic kidney disease is based off of certain risk factors. Again, like you were saying, typically symptoms don't develop until later in the disease. So being proactive and screening high-risk patients who have hypertension, diabetes, lupus, or other kidney diseases like polycystic kidneys, is a good idea, at least an annual screening just to look at kidney function. Of course, history and signs and symptoms are another reason to want to get screened, or if maybe you're in the hospital, you have acute kidney injury, you could potentially progress towards end-stage renal disease, and that's something you need to watch out for. So a couple ways to diagnose CKD. We have blood tests where we're looking at the glomerular filtrate rate. We're looking at labs, your creatinine is big. That's probably the largest red flag when looking at lab values. If the creatinine is going up, there's something going on with the kidneys, possibly something damaging to them. So looking at GFR, which a normal filtrate rate here is greater than 90, and there are 5 stages. You got stage 1 all the way to end-stage renal disease, where your kidneys are almost not functioning any or at all. So you're measuring the amount of waste in the blood, and that indicates that the kidneys are not doing their job. There's also a urine test where you can look at levels of albumin and creatinine. As you progress through kidney disease, typically you're producing less urine, and the urine that you do create is very concentrated. So we're looking at the concentration of albumin and creatinine per gram of urine. And the more concentrated it is, the later on in the disease you are. The most definitive way to diagnose CKD is through a kidney biopsy, where you can look at a cellular level and look at cellular damage, or look at, damage ultimately to nephrons. And there are other ways to visualize the kidneys through ultrasound, MRI, and CT, but they're not definitive like a kidney biopsy. So treatment, again, best thing you can do is try to manage the factors that are causing the kidney disease. So hypertension, diabetes are probably the greatest, diabetes actually being the top factor related to kidney disease. Smoking cessation if you're a smoker, as well as weight management. Improving these lifestyles, ultimately can help hypertension, diabetes, but can also prevent further damage of kidney disease. Dietary control becomes really important as you progress into the later stages. Your electrolytes, sodium, potassium, phosphate, are very, very out of balance as you progress towards end-stage renal disease, as well as water retention. So you have to be careful about how much you're drinking because you are not urinating. So, low sodium, low protein, low phosphate diet is best. You also need to be low protein, again, because the kidneys are not able to filter out a lot of foods that are high in phosphate, which are your red meats, your dairy products, eggs, fish. You want to stick to lean meats, which are your chickens and your turkey. And as you develop to end-stage renal disease, your energy source should mainly be carbs, which is kind of tricky because most people who develop end-stage renal disease are diabetic, so there's a balance there. Increase intakes of vitamin D and calcium, just because you do have high levels of phosphate, you kind of want to counteract that to prevent, osteoporosis or bone damage. And there are a couple, phosphate binders, just because, you may not be able to completely outweigh that balance. Dialysis is ultimately the treatment for end-stage renal disease. Hemodialysis and peritoneal dialysis, which is the act of cleaning white waste products out of the blood. So hemodialysis, which is like your artificial kidney, you're connected to a machine. Typically you have a fistula, some sort of graft or catheter where blood is drawn out, filtered through the machine, and placed back in. Hemodialysis is, it's difficult for a lot of people because typically treatments are 4 hours long and you have to do them 3 to 4 times a week. An alternative option for some people is peritoneal dialysis, where the peritoneal cavity is used as a filter for removing waste from the body. And there are 2 types. There's continuous ambulatory peritoneal dialysis and continuous cycling peritoneal dialysis, which is probably the one you've heard of most. That's where you filter in the dialysis solution overnight, let it sit, it pulls out all the waste, and then it drains in the morning. Another option is a kidney transplant. This doesn't occur very often just because there's a very strict screening process, and not a lot of people who are giving up kidneys. Sometimes families or people who may be a match can donate a kidney to you, but again, it's not very often. But ultimately, it can eliminate chronic kidney disease. You don't have to do dialysis, you may not have as many diet restrictions, and your quality of life is typically improved. Some other things to consider when you have kidney disease: you want to avoid nephrotoxic agents and medications. Ibuprofen or your NSAIDs, they act on the kidneys, or they're filtered through the kidneys, not a good idea. And certain antibiotics are very toxic, you want to avoid those as well. Diuretics such as Lasix are also very toxic. Sometimes erythropoietin needs to be replaced, especially end-stage renal disease, because these patients are anemic, because the kidneys naturally produce erythropoietin, which stimulates red blood cells, and that is not happening when the kidneys are dead. So we'll look at a case study here. A 64-year-old African-American female with a history of hypertension, type 2 diabetes, and hyperlipidemia presents to her PCP with increased swelling in her hands and feet, fatigue, and a loss of appetite over the last few months. She also states that her blood pressure readings have been averaging 150/90 on her home device, which is higher than usual. Her current vitals at the office are blood pressure 162/94, heart rate 98, respiration 16, temperature 98.3, and O2 saturation 94%. She's 5'2" and weighs 182 pounds. She states being compliant with her medications and even took her lisinopril and hydrochlorothiazide this morning. So what are some risk factors the patient has for developing kidney disease? So first off, she's a female. Women tend to develop kidney disease more often than men, but men who develop the disease progress a lot faster towards end-stage renal disease. She's also African American. African American populations and some Asian populations are at a greater risk for developing kidney disease. We also see that she has hypertension, type 2 diabetes, and her blood pressure is clearly not being well controlled with the lisinopril and the diuretic, the hydrochlorothiazide. And again, diabetes being a great risk as well. So those are some of probably the greatest risk factors. She's also overweight. If you calculate her BMI, it's greater than 30. So looks like her primary doctor ordered fasting lab work, and we have the results listed of the metabolic panel, and which of the following lab results would indicate possible kidney disease. So electrolytes look okay, sodium's a little elevated, potassium's high normal. BUN and creatinine are probably the greatest red flags for us nurses when we're looking at labs. Creatinine is slightly elevated, as well as BUN. So that could indicate there is something going on with the kidneys. Also, it looks like her fasting blood glucose is elevated, 115, so she's probably not having great diabetic control. So again, creatinine and BUN, probably the biggest flags that something is going on with the kidneys. So it looks like we have her GFR, and it is 82. So what stage of CKD is this classified as? So if we go back up to our scale, which we see, stage 1, GFR may be normal. It looks like we may be in stage 2. Again, GFR is 82, which does fall into that category. So still pretty early stage, can possibly be modified. So, what health modifications can she make in order to prevent further kidney damage? So I'd say probably the best thing you can do is try to improve state of hypertension, as well as better diabetic control. Because again, those two are the two greatest factors for kidney damage. She also is, overweight. Diet modifications, lifestyle changes can help improve as well the hypertension and diabetes, but put a little less stress on her kidneys. Diet restrictions such as eliminating high salt foods would also be good for the hypertension, as well as for the kidneys, which aren't filtering as well. So that sums it up for CKD, chronic kidney disease.